My name is Chris Johnson, and I'm an emergency physician, and I'm going to talk to you today about the opioid epidemic. I have been involved in fighting this epidemic and this crisis and watched it evolve from my experience as an ER physician for the last 15 years. I've sort of had a seat on the front lines, if you will. And unlike some of the other talks or other presentations you might have heard about this epidemic, I want to talk to you about how it happened and maybe more importantly, why it happened. And I'm going to tell you right now, it was not an accident. No one should leave this lecture wondering, oh, I guess no one saw that coming. People saw it coming. And I'm going to talk to you about how that happened. And I'm going to begin with an apology. On the behalf of the medical industry, we failed you. Those of us in charge of looking out for your health and safety failed you. And I'm going to detail that failure in the next 17 minutes. My background, I'm originally from Virginia, and I moved to Minnesota to train emergency medicine at Hennepin County Medical Center, and I trained there from 2000 to 2003, and that was my introduction to the problem of substance use. And I'll be honest, when you train and work in a county hospital, you can be a little dismissive of it, because in a county hospital population, you see lots of social pathology, broken families, parents incarcerated, lack of opportunities in education, and you kind of think, well, substance use goes along with that. But then in 2003, I graduated my residency and I began practicing here at Methodist Hospital in St. Louis Park. And I was seeing the same thing. I couldn't go a shift without seeing a patient coming in with chronic pain exacerbation or possibly an overdose on high doses of opioids that they were taking every day. And this is why I began investigating the cause of this problem and hopefully come up with some solutions. So the problem, what are opioids and why are we talking about them? Well, a little history. The use of opioids as a medicine for pain goes back as far as written civilization. The Greeks, the Assyrians, the Persians all documented use of this medicinal plant for the use and treatment of pain. And the traditional method of getting morphine was this. This is the seed pod of the opium poppy, Papaver somniferum, and the way you collected that medicine was you made a slice in it and collected this milky substance which contains morphine. Now, the reason it's called somniferum actually goes back to Roman mythology. Somnus was the god of sleep, and so when we give patients, or you've seen someone receive these drugs, they become tired or sleepy, they are somnolent. And as we all remember, Somnus first appeared in our literature with Ovid's Metamorphoses, which was the Latin epic poem detailing of the history of the world up until Julius Caesar in 15 volumes. I thought the first 9 volumes flew by the way. But the last 6, it's get to the Rubicon. You got an army. And actually, morphine comes to us from mythology as well. Morpheus was the Greek god of dreams. And opioids help treat pain in 2 basic ways. One is that they actually block the strength of the pain nerve signal from periphery to your spinal cord. And so that inhibits the experience of pain. But the more important one for our purposes is this. Opioids make you feel good. And by altering your mood, they alter your perception of pain. Pain is an emotional experience, sort of like all of life is. And what opioids do is they increase your mood by increasing dopamine in your reward center. And this is a simplified version, but if this is your brain and your reward center without opioids, and you have a little steady stream of dopamine in your reward center, and your brain feels, meh, I'm okay. And then what happens with opioids, heroin, morphine, whatever, is that you have this flood of dopamine, and you think, my God, that was awesome. And that is how it affects your experience of pain. The problem is that opioids carry risk. They also bind receptors in your brain that control your breathing, and in high enough doses can stop your breathing. And once you stop breathing, you've got a few minutes to restore oxygen to your brain or heart, or you die thereafter of asphyxiation or cardiac arrest. So what's the problem? The problem is that the United States has 4.5% of the world's population, but we consume 30% of the world's opioid pain relievers. That sounds crazy. Was it always like this? It was not. From the years 1992 to 2012, the number of prescriptions of opioids in this country tripled. And I don't have to tell you, the population of this country did not triple. But the number of prescriptions is actually only part of the story. Here's another part. The size of the prescriptions got bigger. So it wasn't just the number of prescriptions being written, the amount of opioid in every prescription massively increased. This graph here, you can tell that these are years at the bottom, but this is oxycodone consumption in the United States in blue and Europe in red. And so here we are, oxycodone is the pain reliever in Percocet. So here we are, a little bit above Europe per person, up until the mid-90s, and then we did that. So it wasn't just the number, it was the size of the pills. We had this massive increase in opioid exposure in this population coming from the medical industry. But that's only part of our problem now. You guys have all seen the stories about heroin and fentanyl, and I would encourage you not to view these as separate problems. They are intimately related and followed on the heels of the increase in opioid prescribing. These are opioids. They bind the same places of the brain. Do not view them as dramatically separate chemicals, okay? 3 out of 4 users of heroin began with pills. And often what happens is that a patient who became dependent on the pills over years and found their supply getting more difficult to come by or too expensive, they would turn to heroin, which was often cheaper. The result of this massive increase in opioid prescribing and now uses of heroin and fentanyl has led to a massive increase in overdose deaths. In the year 1999, the total number of opioid overdose deaths in this country was 6,000. That was 4,000 from prescription opioids and then another 2,000 from heroin. In 2016, that number had climbed to 50,000. If you want to know what 50,000 looks like, well, that would be 16 World Trade Centers, and you're still 2,000 short. And all of you might remember, we went to war over just one of these. The United States has 4.5% of the world's population, but we have 27, almost 28% of the world's drug overdose deaths. So how and why did this happen? This has been a problem that we've seen in the inner cities, but then it's also now moved out to the suburbs and the affluent. It has affected some of our greatest artists, but it doesn't spare the athletes. So how and why did this happen? I would like to tell you that it was good intentions gone awry, perfect storm, wrong place, wrong time, but that is simply not true. The medical industry has changed dramatically in the last 20 years. In particular, the power and influence of the pharmaceutical industry and the ascendance in my profession, again, of meeting corporate imperatives above all else. So how did the opioid manufacturers gain control of the marketplace? They did a number of tactics that I'm going to talk you through. Number one is this. They recruit pain specialists at academic centers to be the sort of key opinion leaders and thought leaders, and their goal is to convince the medical community, workaday docs like people like me, that our reluctance to use opioids for chronic pain conditions was misplaced, that opioids were safer than we had thought they were, and that there was so much pain out there. We were negligent in how much pain we were permitting to occur, that pain was an undertreated epidemic. There was a number of these doctors that they recruited, but possibly the most important one was this gentleman here, Dr. Russell Portnoy. He was the subject of the Wall Street Journal article, Pain Drug Champion Has Second Thoughts, published in 2012. He saw his job as rehabilitating the medical community of opiophobics, people with an irrational fear of opiates. He was president of the American Pain Society in 1995, and it was the American Pain Society that came up with this. Pain was a vital sign. I remember these buttons when I was a resident. My faculty had it, I had it. You wore them on your scrubs. Patients, pain was to be taken as seriously as blood pressure, heart rate, temperature in terms of predicting potential morbidity for a patient. That's how seriously we were to take their reported pain levels. Dr. Portnoy published an article, a position statement in the Clinical Journal of Pain in 1996, stating that the risk of addiction from opiates when used for pain was less than 1%. Less than 1%. Boy, that sure sounds safer than I was led to believe. Do you know where that less than 1% statistic came from? It came from an article in the New England Journal of Medicine. It was published in 1980 by Jane Porter and Herschel Jick, and it demonstrated that opioids were less than 1% became addicted to opiates. And I'm going to use the balance of my time to go through that study, the statistics. I'm just kidding. You can read the whole thing in 90 seconds. This is it. It was a 5-sentence letter to the editor. This is the study that supposedly proved that opiates for use with pain, they weren't addictive. Now, all they did was they didn't actually intend this to say that at all. I mean, remember, this was written in 1980, and like 16 years later, they're now saying it proves opiates aren't addictive? All they did was they followed hospitalized patients who had an acute injury, about 12,000 of them, and then followed them afterwards to see how many developed addiction. They weren't put on opiates indefinitely. These were acute injury patients who just received a dose or two in the hospital. It said nothing about treating chronic pain with opiates. And this was the great failure of medical ethics. This is where we truly let the population down, because that sort of paragraph is, in scientific terms, is called an observational study. You look after the fact and you observed. That's interesting, okay? That's the beginning of the process. That's not the end. What you should do after you observe this is like, how do we prove this? Do we think that more people can take these safely indefinitely? Let's do an experiment. The experiment was never done. The longest experiment done for opiates for use with chronic pain was 12 weeks. Most were just 6. It is on that basis that we started prescribing opioids on an indefinite basis to patients. Now, what does Dr. Portnoy say now about opiates? Well, in a taped interview, I gave innumerable lectures about addiction in the 80s and 90s that weren't true. If I had an inkling of what I know now then, I wouldn't have spoken the way I spoke. By the way, the Wall Street Journal also identified millions in donations to his pain clinic, which pays him from opioid manufacturers. Tactic 2, market to the primary care doctors. This was not done until 1996, and one product changed all that. OxyContin, released by Purdue Pharma in 1996 as a continuous release preparation of oxycodone, which again is the pain reliever in Percocet. Prior to 1996 in OxyContin, extended release opioids or ongoing use of opioids was reserved for hospice patients. It was prescribed typically by pain specialists and cancer doctors for people at sort of end-of-life care. But here's the thing. You can't make billions on hospice patients. First, there aren't that many. And then number 2, they expire. You can make billions on back pain. And that's exactly what they set out to do. And the way you get to back pain and treat people for a long time, and the most people, is you get to primary care. And that's exactly what happened. In unprecedented numbers, drug representatives flooded the primary care clinics, often making a visit every week. They would have gifts and food and flattery. There was multiple, like this, 40 conferences in 5 years. That's like more than every 2 months. And they invited the doctors, the nurses, the pharmacists, everyone involved in the opiate delivery food chain was included. And they didn't forget the patients. For patients, you got free drugs. OxyContin had a starter coupon program where your first prescription was free. Now tell me that isn't like the creepy guy outside the high school. With a little bag, because I'm your friend. Here, just try this. Tactic 3, influence government and regulatory bodies to favor increased prescribing. You needed to do this for a couple reasons. One is you still had to get approval for your product to make sure you could, it was indicated and to market it. And the other reason is that while the pain specialists sort of gave us permission to prescribe, if you really want to increase prescribing, have a stick. Not just a carrot, but a stick. And in 1992, the primary client of the FDA since 1992 is basically the pharmaceutical industry. And this is a direct consequence of something called the Prescription Drug User Fee Act. Half of the FDA's budget is now provided by the industry. And that actually, that came out of the AIDS crisis, actually. It wasn't some malevolent thing back then. In the 1980s, we had all these people with HIV, and they're expiring, and there's this clamor, like, what are we going to do for all these patients? And the FDA was overwhelmed and said, look, we'd like to do these trials to get you helpful medicines, but we don't have the budget to do it, and so the industry stepped in. But ever since then, they've been dependent on the industry for their funding, and it is very difficult for a regulatory body to regulate an industry when it depends on that industry for money. And in the 1990s, they approved opiates for chronic pain, again, based on no studies longer than 12 weeks. And here's the stick part. Get those pain scores down. The pharmaceutical industry influenced the Joint Commission, which is responsible for evaluating and accrediting hospitals. This was on the wall of every emergency department room I worked in. 0 to 10, what's your pain level at? Nurses were compelled to recheck on the patients. What's your pain level? We got to get that down. The Joint Commission published a guide in 2001 about pain management, and that was funded by Purdue Pharma and told us that the risks of opiate use had been exaggerated. Tactic 4, they blur the lines between patient advocacy and academic groups and marketing. Take a look at this group, Partners Against Pain. Pain, it's not something you need to, you have to manage alone, you have a partner. And look, they're holding hands. Like who would argue against that? They're fighting pain and loneliness. But if you scroll down to the bottom of the screen, this was purely a creation of Purdue Pharma, what they call unbranded outreach. That was 1993. And take a close look at these academic societies. This is the American Academy of Pain Management. That's the former president, Dr. Lynn Webster. We have an epidemic on our hands, and the status quo is failing us. Curious thing about that academy, they've got a corporate council. And look who's on it. Purdue Pharma, Endo, Pfizer, all makers of opiates. So is pharma the one to blame? Well, they certainly are part of it. I mean, this was their marketing strategy. But I want to caution you that it's too easy to just blame the pharmaceutical industry. The pharmaceutical industry sells all over the world. This crisis didn't happen in Japan. It didn't happen in Germany. It happened here. So what is it? Why did it happen here as opposed to these other countries that they have patients who have chronic pain, pharmaceuticals they sell them there too? Well, this is from my performance review in the year 2012. Those are my arms. I'm very proud. Chris, we are also proud of you for the work you are doing with chronic pain, but it's such a fine line between increasing risk of opiate addiction and HCAP scores. You know what HCAP scores are? Those are your patient satisfaction surveys. They do not exist for your health. They exist for you as a customer to get you coming back. Medicine in America, unlike other countries, is first and foremost a business enterprise. And every business enterprise has as its primary obligation is to make money for the owners and investors, and in the process enrich the participants. Even not-for-profits have investors, they're bondholders. In fact, fiduciary responsibility, which all these executives undertake, compels them to do this. For this reason, American medicine is not incentivized for your long-term health. It is incentivized to sell you healthcare services. But this leads to an unavoidable conflict in healthcare. Healthy patients don't need to buy healthcare. Now, why would this pose a risk for opioid crisis? Because a system driven to sell services thrives when patients are in a state of chronic disease, and that is precisely the model that opiates employ. It checked off a lot of boxes for us. It allowed us to expand the customer base. Pain is a vital sign. Pain is an epidemic. Pills solve the problem. Visits are quick. You can see tons of patients and turn them over. Pills are by prescription only. We corner the market. Tylenol doesn't solve this. Opioids do. And treatment is lifelong and indefinite. Patients become dependent on these opioids and keep coming back. So what do we do about this? Two paths forward, a short term and a long term. In the short term, we need to prevent creating new opiate-dependent patients. In the long term, reform a system that created this. Studies do not support the use of these medicines for management of chronic pain. If you have back, joint, neck pain, do not start these medicines. They don't work in the long term. Medical-assisted therapy helps patients who have developed opiate use disorder, but is a very imperfect solution. It cuts your rate of overdose in about half, but your risk of death is still 3 to 5 times higher if you're on medical-assisted therapy than if you never developed the problem at all. Bottom line is this: the American system is a failure. In addition to overcharging you, we are not getting you good medicine, good therapy that is well driven by science. And it's not because doctors want to cause harm. Our incentives are broken. We need a different type of system, one that rewards outcomes or at least stops rewarding just the sales of services. This would be more in line with the Hippocratic Oath and what other countries do. So what can we do going forward? Well, we can at least acknowledge that opioids don't work for chronic pain. As far as I'm aware, the American Medical Association, the American Heart Association, none of them have acknowledged this. We need to interrupt the financial relationship between doctors and the industry. We need to make research more scientific and make the FDA independent. And we need to stop volume-based revenue for doctors and clinics. Oh, and let's stop this whole talk about morality. And this is a challenge I would even say to the traditional recovery industry. We have created addiction in mice, in chimpanzees, insects, pigeons. We don't talk to them about their character defects. So this is my final slide. I conclude here. This is a painting by Edward Munch. It's called Despair. It is derived from the Latin verb spero, which means to hope, so despair literally means without hope. I got involved in this problem because I was initially very frustrated with trying to manage these patients in the emergency department, but the more you learn about these patients and what they're going through and what their families are going through, it is a world of suck. You do not want to wish that on anyone. And so I argue for reducing opioids not because I want them to suffer pain, but because I don't want them to enter this life of misery. And I want a healthier system for my colleagues, many who are great people, that want to practice effective, compassionate medicine, because we all deserve better. Thanks very much.